Good evening, everybody, and welcome to another interdisciplinary panel discussion over webinar. This one is on a collaborative approach to supporting people at risk of suicide and is hosted by the Mental Health Professionals Network. Now, our video is a little slower than our audio, so I apologise, I got a bit confused then by a big 3, 2, 1. If you have, we'll give you some technical instructions in a moment. And first of all, I'd just like to introduce our panel. My name's Mary Elias and I'm a general practitioner and psychotherapist. I work at Headspace in Cairns in North Queensland, and I've been involved with a few of these webinars before. Tim Wand is a mental health nurse practitioner. He works in an emergency department in Sydney and is also a senior lecturer in mental health clinical practice. Tim, how are things in Sydney today?
Yeah, fine, thanks, Mary. Thanks for having me. Welcome, everybody.
Thank you for joining us. And David Webb is a suicide survivor. So he's a person who's had an extended experience of suicidal thoughts and feelings, which he has survived. And he particularly noticed that there was an absence in the literature about voices of people who have survived. And also a lack of conversation about spirituality around suicide, which was something that really helped him. He went on to do a PhD, and out of that came a book called Thinking About Suicide. David, it's fantastic to have you involved in our discussion tonight, and I noticed that you're currently living in Castlemaine. So I wondered if you wanted to tell us a tiny bit about Castlemaine.
Castlemaine, well, it's an old gold mining town from the 1850s. It's about 120 k's outside of Melbourne, where I've lived most of my life, and it's a wonderful place for my semi-retirement.
Thank you, and welcome to our panel. I think the Wild Colonial Boy came from Castlemaine, if I recall, from the song.
Yeah, he lives next door.
Fantastic. And I'd like to welcome Susan Beaton, who's a psychologist. Now, Susan is very involved with Beyond Blue and has also been very involved at a high level with Lifeline and had a Churchill Fellowship to study suicide prevention in the States and in Australia. And Susan, I believe you're currently living in Melbourne, is that correct?
That's right. I've recently moved to take up this position with Beyond Blue, helping them with suicide prevention.
Welcome, Susan. And Michael Dudley is the psychiatrist on our panel. Michael also is a lecturer at university and has a particular interest and experience in youth suicide. And Michael, you're calling in from Sydney.
That's correct. Yeah, thanks for the invitation, Mary.
Thank you very much. Now, I'd just like to let the participants know that there's currently approaching 500 of you online this evening, and we had 1,500 people register to participate tonight. So this is the biggest so far of the MHPN webinars. So it's obviously a topic that people are really interested to hear about. Just some ground rules. This is just to make sure that everyone has the opportunity to get the most out of it. Be respectful of everybody. Just remember that anything you write in the chat room or the technical help room is visible to everybody. So feel welcome to comment to each other and respond to each other's comments. If you have technical issues, please do use the technical help box. And at the end of the webinar, there'll be an opportunity to provide feedback. And your feedback is certainly noted by MHPN and has been used to inform improvements in subsequent webinars. So please contribute to the feedback. At the end of tonight's session, we're hoping that people will be better equipped to raise awareness of the indicators and stigma associated with suicidality, to identify the key principles of the featured panellists' approach in assessing, treating and supporting people at risk of suicide, and to identify the merits, challenges and opportunities in providing collaborative care to people at risk of suicide. And tonight we're going to be meeting Caitlin, who's a young woman studying at university, who has presented via the university counsellor and then the GP to a mental health nurse. You've probably all read the case study beforehand. And actually I forgot to mention the panellists' biographies are also on the MHPN website if you'd like to know more about them. And the slides will be up later, all the resources and the case studies there as well. So what I would first of all like to do, since it was a mental health nurse who first met, who's having the longer interview with Caitlin to begin with, we thought that we'd invite Tim to respond first. The way that, for those of you who haven't been in these before, each of our panellists will give a short response to Caitlin from their perspective, and then we'll have a discussion between the panellists, taking into account the questions that you've submitted and questions that the panellists have for each other. So I'd like to hand over now, first of all, to Tim. Tim, if you could talk to us about how you might respond to Caitlin if you were to meet her. Thanks very much, Tim.
Thanks, Mary, and hi again, panel, and welcome to all the audience members who have signed on for this webinar this evening. Looking at the case of Caitlin, and I've got to say it's a pretty common type of scenario for someone who might see in the emergency department setting, and of course being surrounded by a number of university settings, it's not uncommon for me to see university students. Just gleaning some of the main points from the history that you all have, the things that strike me immediately to be factors to consider Caitlin's challenging developmental background, which I think is a common thread with a lot of people that we see in our work who at times struggle with difficulties managing their emotions and controlling their distress. A history of family disruption. There's a stepfather mentioned, mention of the real father, and some conflict with a mother as well, which seems to have been ameliorated more recently. Overdose in the past, of course, that's an important consideration. But so too is her previous involuntary hospitalisation, but also more importantly her attitude towards that. Common presentations that I see are people in heightened states of emotional arousal, with anxiety and stress, and the physical symptoms as well as the mental symptoms associated with that can be quite concerning for people, and then they start to lose sleep, and that only then further compounds their struggle. Those other symptoms or presentation factors are, I think, very important. Just on initial assessment. I'm very much a part of the strengths-based approach, and I'm always looking for positive intention, positive attributes and assets in the individuals I see in the emergency department. And what I can see from the case with Caitlin is that despite adversity in her early childhood, she's managed to support herself into a uni degree. Physiotherapy is a hard university degree, I can assure you, and she's made it the third year as well as working part-time. So to me that's a great strength, and that indicates that on face value it looks like she's had a pretty productive period of wellness. She looks after herself by attending the gym, and there's evidence about the effectiveness of metabolic monitoring exercise and well-being. So I think she has a fair degree of self-efficacy and resilience. One of the pluses as well, and a lot of you will agree that we see a number of people who have had some pretty unfortunate developmental backgrounds often develop, understandably, alcohol and substance misuse issues, and that's an understandable response to difficult situations, but that only makes things worse in the long run. And I'd also be looking at what her resources are. Her mother, and it sounds like her relationship's more healthy, as I mentioned. The friends she has at work who are concerned about her, as mentioned. And her level of motivation, her own resources, her internal resources, her positive attributes, which will be helpful to progress. So in terms of assessment and assistance, look, I've got to just say straight off the bat, and there's one of the resources available to you all, as well as a recent paper I published examining the research evidence for the effectiveness of risk assessment in mental health care. And I don't want to go on about evidence-based practice here and bore you. And I'm not alone, unfortunately, with a lot of colleagues in medicine, nursing and social work who have identified that risk assessment isn't as effective as it's made out to be. And what I think the cascading approach of that is quoting the case from the mental health nurse who's even more worried. I think risk assessment creates an unnecessary level of worry and apprehension amongst us as clinicians, and that inhibits our ability to make considered clinical decisions rather than impulsive ones. And I don't want to sound like I'm being dismissive, but our role as clinicians is to help people who worry, not to be worried. I also really think it's important to try to normalise rather than pathologise people's situations. A 20-year-old university student who's funding herself through university, it's a hard course, and she's had a relationship breakup. That's common, and she should be reassured to know that we see a lot of people in similar circumstances who experience the kind of symptoms she's having in response to the challenging situation. And the 20s is hard for all of us, that's for sure. Crying for no reason is a quote out of the case as well. As I just mentioned, I think Caitlin's got some reasons to be crying, and that should be also explained to her that crying in a situation as compared to the one she is facing is understandable. So let it out, Caitlin, is what I would be suggesting to her. And evidence too of that she's not herself at the moment would indicate that, yep, this has disrupted your life for the time being, but getting back to yourself, your normal cheerful self is our objective, and that these states of distress and depression are kind of understandable responses to adversity. And then I would go on, rather than simply focusing on risk factors as I would, to looking also at an assessment of Caitlin's strengths, her assets, abilities, how she copes, how she gets through. Some health education around symptom management for sure as well, and also sleep's pivotal, as I mentioned earlier. In terms of collaboration, given that's one of the main themes around this presentation, this webinar today, obviously collaborating with Caitlin's really pivotal, and I guess the history of her having an unpleasant experience of being hospitalised against her will is really an important consideration, and unfortunately I see lots of people who are reluctant to seek services in the future due to unpleasant circumstances experienced in the past with forced hospitalisation. And I think we should also acknowledge there are competing risks associated with trying to ameliorate our concerns and worries about people by treating them against their will. And for someone like Caitlin, she faces the added risks of resentment or demoralisation and loss of income, missing out on university and falling behind. So we really do think carefully about our approach here and our response or our reaction. I'll be trying to harness the support of mother and family and friends, and how Caitlin will utilise those resources. I write lots of letters to universities on behalf of students, asking for some consideration in terms of examination, etc., due to the difficult circumstances someone might be undergoing at the moment. So letters of support for the university would be something I'd be thinking of. And also bringing in the support of my colleagues. In the ED, I'm lucky in that I have access to nursing and medical support, a psychiatry team, social work, and community mental health resources, as well as the person's private resources they might have in the wider public. But I think it's important that we collaborate with our colleagues in acute settings, but also in the more broader public and private sector, to share information, to support one another, and to support our fellow human beings in mental distress. Is that it from me, I think?
Yeah, thanks very much, Tim.
No problem.
So I think Caitlin would have been very fortunate if she met you in the general practice, and certainly there are mental health nurses in primary care, so that could well happen. I'd like to invite David now to respond from the perspective of someone who's actually been there. David, you might need to press *6 if you did mute yourself.
Oh, I'm back online?
Yes, you're there. Fantastic. Thank you.
Okay, great.
Actually, we've lost your picture, but we can hear you. So
It's back now, I think.
yeah, you are. Fantastic.
Okay, great. Thanks for the invitation to be part of this evening, and hello to everyone on the panel and in the audience. Before I get into it, just a few slides, I need to make the disclaimer that I'm not a therapist or counsellor of any kind. So my relationship with Caitlin, for instance, would not be one of seeking to give advice or anything like that, which makes it a little bit difficult to respond. But with that in mind, the second point beforehand is what I've got in the next couple of slides is just some dot points, and each one of these dots we could talk about for hours, I think. And I'd like to just put these out there as quickly as I can, run them up the flagpole, and invite people, other panellists and the audience to respond. So just to introduce them, the first thing for me is always what's the social, cultural context in which a person is experiencing suicidal feelings. And for me, the prevailing response in our society to suicide is one of panic, and which to me is based on fear and ignorance and prejudice more than anything else. As a knee-jerk response to just panic. Part of associated with that is the issue of stigma, which gets talked about a lot, but we need to call it by its correct name, which is discrimination. And by that I mean this is something that belongs with those who discriminate against us, against suicidal people. When I look at Caitlin's story and I think, well, what's her likely pathway? Well, she's going to get diagnosed, possibly hospitalised, various forms of coercion, including possibly locked up in hospital and forced to take treatment that she doesn't want. And already in the case study, we know that Caitlin is aware of this risk and is concerned about that. So broadly speaking, I think there's a big issue for the community at large, and perhaps even more so for practitioners in the field, of what I call the politics of suicide, or the politics of suicide prevention. And this is to really draw attention to the power hierarchy within the suicide prevention industry. I'll leave that there. I think there's a lot that can be followed on from that. Some of these points will come up again in the next slides, if I click on that. Okay. So when I look at that context and I ask myself, well, what's missing and what's needed? For me, first and foremost, above everything else, is we need to change the way we think about suicide and suicidal feelings so that we approach the suicidal person with respect for, rather than judgment of the suicidal person. Secondly, we need to adopt a whole person approach. Some might call this holistic. And in my own work, I actually argue that the better starting point for thinking about suicide is to think of it as a crisis of the self. And in particular, I contrast this with the prevailing view that suicide is often seen as the consequence of some notional mental illness, in particular depression, which I regard as unhelpful. Thinking of suicide as a crisis of the self, I think, is a really useful way of opening up a broad conversation that encompasses a truly holistic approach. What else is missing? There's a real desperate need for people in crisis, and it doesn't necessarily have to be a suicidal crisis, but people need to just take time out from the world. So we need sanctuary or asylum in the best sense of the word, or refuge. And I'm hoping Susan might mention later on, I think she's visited the Maytree community in the UK, which is a sanctuary specifically for suicidal people that sounds like it's doing wonderful work. Another hot topic for me is the spiritual dimensions of suicidality. In fact, this more than anything else is what motivated my PhD. And this is both in the sense of what may cause us to feel suicidal, which is, if you like, feelings of spiritual void, spiritual bankruptcy, spiritual dissatisfaction, but also spirituality, spiritual ways of knowing, can offer pathways to recovery and moving on in a way where we can embrace the possibility of life again. The next point for me is also urgent. We need to demedicalise and decriminalise suicide. I put the decriminalise in quotes because it's not strictly speaking illegal now, but anybody who's suicidal runs the risk of our mental health laws, which makes us second-class citizen. We lose the right to liberty. We lose the right to control our own body, and that's a very big issue. So this is what was mentioned in the introduction. There's a real tension there between human rights versus what many people feel as their duty of care obligations. Another point which I come up against again and again is the need to move beyond what I call evidence-based paralysis. This really does come from the medicalisation of suicide, and particularly the medical criteria for what constitutes valid evidence, which may be appropriate for the testing of new drugs or surgical procedures. But the criteria for what constitutes valid evidence in medical settings are just inappropriate and unhelpful when we're trying to understand the complexity of a suicidal crisis. So in fact, what I see with this phrase evidence-based is used more frequently to silence people and to exclude people from the conversation. I hope we can say more about that before the evening's out. For this forum, a key word is collaborative, and I do believe a genuinely collaborative approach is needed. And amongst some of my colleagues, my fellow survivors, we talk about the need for doctors on tap, not on top. And because part of my story was in and out of the drug and alcohol system as well as the mental health system, I think there's a really stark contrast that we can see if we look at the different social and cultural context of those two service sectors. The mental health system is very much driven by a medical approach. Drug and alcohol is very much more genuinely collaborative, where doctors, social workers, psychotherapists, counsellors, a whole range of skills are brought to bear, with nobody particularly in charge, but more in recognition of the diverse skills that we need to bring to bear. And the final point here, which is really the crux of all my research, is that there's a desperate need for what I call the first-person knowledge. Some people call it the consumer perspective. I don't like that word consumer. It's problematic, like many labels in mental health. And I refer to my colleagues in the disability sector, who for many years have campaigned for their rights with the slogan, "Nothing about us without us," which is what we desperately need in mental health. More generally, we're beginning to see a little bit of it, but in suicidality in particular, the first-person expertise is still very much absent. What's the next slide bring? Okay, if I now look at Caitlin, which, as I said, I'm sort of reluctant to do, I do 2 risk assessments, and for me the gold standard, and this comes from the ASHI group, which I think also hopefully Susan will mention, is to ask her. Just ask the suicidal person. It's not dangerous to ask someone if they're feeling suicidal. The danger arises with what happens if they say yes, and how are you going to respond to that if they say yes. And all the other indicators that get used with risk assessment, have they recently done a will, have they tidied up their affairs, all those sorts of things. They're just clues. They're secondary to what really is the gold standard, which is to ask the person themselves. But there's a second risk assessment that needs to be done, which is the danger that she faces from our mental health system. For me, I could never refer someone to our mental health system because I think it's just too dangerous. The dangers of being locked up and having drugs forced upon you that you don't want is a very real risk that many people encounter, many people experience and can tell you about, and it can make an already bad situation very much worse. So I think that's a risk that needs to be considered and weighed up if you want to do any sort of risk assessment. I'd like to try and highlight just some of the unhelpful language that I think we find in the field, which is assessment, diagnosis, illness, sickness, disorder, treatment, relapse. Again, it's mostly medical stuff for what is not primarily a medical issue. I think we need to recognise our own fears when we encounter people like Caitlin. It's scary when someone discloses to you they're feeling suicidal, and your fears about that shouldn't be suppressed. Similarly, we need to be aware of what judgments and prejudices we hold within ourselves. A lot of knee-jerk responses to when we find out that someone's feeling suicidal, and that's part of the context in any conversation. I love this one. It took me years to really appreciate this, but a tremendous skill is the capacity to bear witness to somebody else's pain without judgment and resisting the urge to advise, solve, fix the person, or what I sometimes call the saviour complex. I think some of the most healing support and assistance that you can give is to just be with them in their pain and to bear witness to it. And sort of hand in hand with that is do not feign false empathy. By all means, be sympathetic, be concerned, but to say, I know exactly how you're feeling when it's very obvious that you really don't is really unhelpful. But most of all, I get back to my initial point. Respect and honour her intensely important, meaningful, legitimate, and I would say sacred crisis for self. So I'll finish with a quote from a friend of mine in Melbourne who I asked to write a little something for the back cover of my book. And she gave me this. And I've since learned, as I speak at public forums and people come up to me afterwards, and this caught me by surprise a little bit. I didn't anticipate this. But the most significant, some ways the most radical thing that I say is to honour and respect your suicidal feelings. And this I find this really has an impact on people. And so just to quote Josephine, which is not her real name, she gave me these words for my book, and I think I was just over the moon when I received them. She said, I have never before read anything relating to suicide that speaks of suicidal feelings as being worthy of respect. The possibility that I may actually be able to honour these feelings is a totally new concept, one which is proven to be a catalyst. So it all begins with approaching a person in a human way with the sort of respect that I think most of us would want in any encounter that we might have with anybody else. Thanks very much.
Thanks very much, David. It's just so important for us to all be hearing, as you say, nothing about us without us, and to have your contribution is just invaluable. And I can see that from the chat room as well. We have over 550 people now joining us, and I'd like to invite Susan Beaton, the psychologist, on the panel to respond. Just so that the panel knows, we are actually already running about 10 minutes behind. I had just decided to let David take his time there, and I might be a bit stricter with Susan and Michael, so please forgive me if I do that. Thanks, Susan.
Thanks, Mary. Great to have this opportunity. I just wanted to say hello to Jacinta Hallgood, who's out there in the land of our listeners, who's an excellent clinician in the field, and I'm really appreciating her questions and everybody's discussion. So this is it's wonderful to see everybody engaged. I'm very informed in my 5 minutes now by my Churchill Fellowship, which took me for 3 months travelling, looking at non-clinical support for suicidal crisis. So very much as David has spoken to us, looking at that component of suicidality that is beyond mental illness, that's beyond symptoms, but what is the experience of suicide and how can we support people in a healthy and helpful way to rest gently in a sanctuary space, as David puts it, to come to terms with what this means for them. And really I've got this slide here articulating hope as the signpost that we need to always be holding out for people, because we as clinicians, as mental health professionals, are such a beacon of hope for people who are often, through cognitive restriction, really can't see beyond a suicidal crisis. And much of what I'll speak about has to do with us and what we bring to the equation, whilst alongside of looking at where Caitlin is in her life and what she's experiencing, because I guess along with my church and my 25 years working in suicide prevention, I think it often comes down to we as clinicians need to care more than our anxiety. We need to exhibit compassion more than the liability, the risk. And so in this weighing up of terms, we have to make a stand for people who are vulnerable and put them ahead of our own risk and our own concerns. And I understand that many of us aren't trained in that regard, and it does take training and support and very good supervision to be able to sit alongside of somebody's deep suffering and pain, but only in the sitting alongside of will we truly come to understand that, only by having the courage to ask what that experience is like, and then being quiet and just listening will we even understand, and we can't help unless we understand, and we can't help somebody else. I suppose one of the key features that I want us to focus on is that most people don't want to die, they just don't know how to live. So as we look at Caitlin, it's not so much wanting to stop her from killing herself, but having her understand what life does she want to live and how can we support her in finding a life that's worth living.
Susan, can you just move your microphone just a tiny bit away from your mouth?
Yep.
Just a bit close. Thank you.
Okay, fine. I just put this quote in here, a colleague from Washington State in the US, and I thought it was a really powerful statement, especially for folks who are working with clients or patients who are chronically suicidal. It is our challenge to be that beacon of hope and to always believe that there is a way to find a life that's worth living, and that we need to question ourselves and what we're doing if we can't provide that, if we've given up on hope. In dealing with Caitlin, of course, we will look at the constellation of issues that she brings with her and risk factors, and you've all read the case study, so you'll be aware of all of those. But predominantly, the focus I would have, as Tim said, is on what's going right for Caitlin. What is she doing well? What has she done well in the past? And I would definitely focus on her values and strengths, as Tim has already articulated. I suppose alongside of those strengths and really acknowledging her courage in seeking help and working through some incredibly difficult issues is to acknowledge and validate what has gone on for her. She's left very difficult family circumstances at a very difficult time to move in with her boyfriend. She's been with him for quite a few years, and he's left. So to really acknowledge that loss and grief and pain and validate the feelings that she has. And I suppose alongside of that, having her understand what she may be feeling is a perfectly normal and understandable reaction to those experiences. So her lack of ability to sleep, her lack of ability to concentrate, the cognitive restriction, limited problem solving, her intense emotions that seem to overwhelm her. So have her understand that these are very normal, and to steer away from pathologising, as David has said to us, and have her come to realise this is a key time in her life where she has opportunities to make some choices, and she's she's very able and capable to make those choices when she works alongside with a team, and I would be putting her in touch with that team, so that I would always speak in terms of we can work through these issues that are sticking points in your life. Tell me about the life that you want to live. Talking about suicide with her in a very direct way, asking her about suicide, letting her understand that I can hear these and I can sit with her alongside of that, and that I see it as an opportunity for her to I suppose see the crisis as an opportunity. So for me, suicide is not something to be shied away from, but to go straight towards and to say, this is a common thing that one might feel when you consider what's gone on for you. Let's have a look at that. We're not taking that choice away. You could always make that choice. We're not denying that as a choice, but I'm just not sure that you've got all the coping skills and problem-solving skills that you might need, because given the grief and loss and issues that are going on, of course you don't have access to those things. So I would invite her to work and spend some time on perhaps growing some skills, learning some mindfulness, perhaps taking on some CBT, some ACT, finding a place that was a good fit for her and growing some skills. I'd be really keen for all of you to have a look at the AESI Group's website. This is a group of clinicians who have for many years been meeting. They're a bit of a renegade group, in fact, but very focused on the fact that our healthcare systems, as David has said, are often empathic and unhelpful. And these guidelines is what they use to look at how can we actually truly understand what's going on for somebody else. And they're very invested in that. David Jobs is a very strong partner in that group. He's a professor at Catholic University in Washington DC, and I really recommend his work. He's written a number of articles. I put one of those on the website, and this is a book that I would strongly recommend to guide how you might work alongside of somebody in a collaborative way. And as David said, collaboration starts with working with the person as well as working with the team, the psychiatrist, the doctor, the psychologist. So I would just highly recommend that you investigate the collaborative approach to managing suicide risk. I put this slide in just so much to bring attention to safety planning. Barbara Stanley and Greg Brown have done a lot of work in safety planning, and I would use this as a key to working with somebody so that they feel safe. It's often quite anxious making for an individual to feel suicidal, and having strategies, having plans in place, knowing who you're going to seek some help from if the wheels fall off at 2 o'clock in the morning, letting them know how available you are and how approachable you are out of hours. You might offer follow-up calls yourself. So I'm just letting you know quite a few, quickly flipping through these resources here. Alice Cole-King, a Welsh consultant liaison psychiatrist that I got to meet on my Churchill, offers a beautiful, I think, synopsis of how a risk assessment is something that is just a part of how we come to understand. If we see it as something that's quantifying and ticking boxes, this is not going to be helpful to somebody. And I almost think that today's discussion is kind of the beyond risk assessment approach to suicide prevention. More resources. If I was working with Caitlin, I would make sure that she had maybe a little toolkit. I would give her a hope kit. I would put some things into that hope kit. I would give her these cheat sheet of things that she might, when she's cognitively restricted, have her understand that she's not going to be thinking straight if these suicidal thoughts come back to her. And she might need to kind of outsource to some resources to have a hope kit that has, music that she likes, a photograph of her mum, if she's got a pet, a lock of her pet's hair, the things that can hold her to life and have her really ask herself those questions about, what it is that helps me to live. This is a companion piece for professionals, and I really recommend that you have a look at that online. So a lot of these slides, I've just taken screenshots of useful resources, and if you were to buy any book to support somebody who is suicidal, it would be this one that's come out of the AEC group. Conrad Michel and David Jobs are two of the clinicians. So I wanted to draw attention to the US National Suicide Prevention Alliance, which is a public-private partnership. This is a 2011 publication, and they're looking at a zero tolerance for suicide within health settings, and I think that this is something that we need to be aiming for, and I just draw your attention to that as a thrust towards any institution. We should be absolutely prioritising people and not treating them in a desensitised way, in a dismissive way. David brings up a beautiful example for us all about the incredible breadth and value of listening to people who have been there, the presumption that we have to develop services without consideration of that experience. So I've just given you two web links where the words of people who have attempted suicide are written down for you. And just coming back to the challenge that we have as professionals, it's very, very difficult to sit alongside of somebody's suicidality. So there are times when we might even avoid asking, but that's about, we have to self-reflect and ask ourselves, why am I not asking? I've got 5 minutes before this patient's finishing and I've got somebody else. Is that why I'm not asking? So I think there's a lot of self-reflection we we need to take on board. So these two websites really give you an opportunity to sort of immerse yourself in that experience, because only when we can, as health professionals, sit alongside of without holding back. You know, somebody who's suicidal is going to know when you don't want to go there, when you ask, but in a tentative way. So we have to find the supports that we need in supervision to be able to sit alongside of somebody so that they can be safely in that place to find their way of understanding what suicidality means to them and how they might work through that. And as David said, Maytree is a house in North London, which is specifically designed for suicidal people. Most mental health settings exclude people who are suicidal because they don't want to take on such a risk. Maytree invites only suicidal people, and their website can provide you with some information. They've had Stephen Briggs has done some evaluation of the work that they're doing. It's a very interesting place to visit, and I have to say, as a psychologist, it was challenging for me to walk in there and understand how the place runs with volunteers and a lot of conversation. It's based on befriending. It's not a therapeutic model, although I'm sure it is therapeutic. So I think, Mary, I might need to wind up here, and I'm just going to mention two resources. There's a gentleman called Robin Youngson, who's a New Zealand anaesthetist, who's written a book called Time to Care, and he really challenges us to look at our healthcare systems and what we value in those healthcare systems. He has a website called Hearts in Healthcare, and there's also another incredibly valuable book called Intelligent Kindness, which looks at how we can come together to reassert what's important in healthcare systems. So, Mary, I think that's my 5 minutes.
Thanks very much, Susan. Once again, I just feel that the things that you are bringing to the audience are so new and refreshing and just worth hearing, so I'll just let everyone go on longer. And the resources that people have raised that are not on the slides will be made available later, so don't panic if you miss them. Now, Michael, last but by no means least, I'd very much like to hear your response to Caitlin. Thanks.
Thanks for the invitation, Mary. Can you hear me all right?
Yes, it's excellent.
Oh, good. Okay. This is, I guess, like David, I'd like to probably run a few ideas up the flagpole. Sorry, I've got a notice to reactivate my camera here.
And I'll just advance the slides. We can hear you, so you can keep...
Oh, okay, good. Yeah, lovely. Okay. So, look, I guess that, as I said, it's probably just skating through one or two things and then coming to Caitlin. I think suicide's a barometer of how well we care about people as a society. We know that it's a major public health issue, but I think it does really indicate, our care for each other. And I think Susan and all the presenters actually touched on the fact that the things that make people suicidal or motivate this unbearable pain, and I guess Thomas Joyner talks about foul belongingness and perceived burdensomeness, and also the acquired capacity to self-injure. But we also have to ask what stigma contributes to suicidality. There's public scepticism about suicide prevention, which may overlap with pessimism. I guess it's hard to separate those things, but certainly this is true in the general public, and it's also true amongst health professionals. And I guess that's really what some of the discussion to date, Mary, has been focusing on, the fact that we as professionals are not immune. We don't sit above this. We have our own responses, and we have to be very aware of this. Certainly a study by Diego de Leo pointed out that treatment satisfaction for suicide attempt survivors was very mixed, for a third and poor for a fifth, and about 30% reported attitudes of professionals as mixed, and more than a third as poor or very poor. So this is it's a hazardous area, I think, for people attending emergency services and encountering people who genuinely will connect with them. It's a lottery to some extent. I wanted to highlight stigma, which comprises illiteracy and prejudice and discrimination. David's already touched on that. And I guess the role of ambivalence for all of us in dealing with people on the edge of life and dealing with our own emotional responses and having our internal supervisor working as well as getting external supervision as required. I think that trauma and stigma both constrain help for suicidality for our clients, young men in particular, various marginalised groups, suicide bereaved people, suicide attempt survivors, but also people like Caitlin who've been burnt by the system. Professionals also are constrained by, and this has already been alluded to, that the risk assessment processes cannot, again, they're very useful in a sense, which I'll come to. They don't predict suicidal acts, and to some extent organisational demands may elevate them above therapeutic relationships, and certainly organisations, doctors and psychiatrists especially, may be blamed or sued for negligence, resulting in untold financial and emotional costs and defensive practice. So there's certainly requirements there about standards of care and about accurate documentation and so on, but to some extent the duty of care is trumping rights, and this is a concern, I think. There are no specific anti-suicide therapies. There are leading groups that don't recommend any definitive intervention, and we should remind ourselves that trained communities and individuals who engage with the person's distress in pragmatic and timely ways and offer hope and compassion can be as effective as paid helping professionals in sustaining life. So connection's critical. It's not to mitigate the impact of trained people, but this is something that can be effectively delivered by anyone who is in the space where they're able to do that. Various groups and individuals are reclaiming the precept of listening and learning from the suicidal persons, and David and Susan and Tim have all alluded to this. Building relationships through courtesy and respect, clear explanations of process and content, and delivering on what's promised. So I guess in relation to Caitlin, I think we should avoid medicalising, as sometimes drug companies and sometimes psychiatrists do. Try to use psychiatric language and diagnosis where needed, obviously, but if possible, sparingly. There is a place for it, but we also have to make sure it doesn't take over the narrative and avoid the pitfall of using taxonomies to classify people.
Michael, can you just move your microphone just slightly away from your mouth?
Yep. How's that?
Yeah, that's good, thank you.
Is that okay? Great, yeah.
Better.
As I was saying, Mary, the clinical risk assessment and categorisation don't predict suicidal actions. We know that risk factors are useful at an aggregate level in terms of aggregate data, but the practice of psychosocial assessment, including risk assessment, does underpin a comprehensive approach to care. And there is evidence, such as it is from case control studies, showing that routine accident and emergency assessment can prevent self-harm, but we also know that A&Es can be unfriendly places. They can be illiterate and censorious about self-harm. They can be poorly informed about services and poorly organised so that people can be alienated and lost without trace. So there's a need to improve staff knowledge and confidence because of this lack of knowledge, staff knowledge about self-harm, poor communication between staff and with patients, suboptimal follow-up and lack of knowledge about its services contributing to suicide. And there are various approaches being nominated and being, explored currently in terms of motivational interviewing, CBT, for people people in emergency departments who are suicidal. This is in the early stages, but it's being developed. Diagnosis is science, yes, but it's also a cultural matter, and it also involves marketing and the exercise of power. And clinical depression is not as common as drug companies and some national awareness programs would have us believe. I'm thinking of the UK Defeat Depression program here and some research that happened about that. But its melancholic form has an ancient pedigree, and clinical depression is qualitatively different to sadness or grief. So, grief obviously is a differential diagnosis for Caitlin. It's disabling, potentially dangerous. It can occur with other conditions. I've mentioned eating disorders here in relation to Caitlin, but of course obviously anxiety and panic. And it's often inadequately recognised and treated before and after suicide attempts. There's important information about that. So it does need to be detected. It's often, comorbid with other problems. Psychiatric hospitalisation, reportedly in cohort and case control studies, reduces suicide risk, including compulsory hospitalisation, believe it or not, but its hidden injuries are rarely examined or discussed. So I guess there's an important message to us as practitioners here, particularly to the doctors amongst us, to not admit and or treat or seclude or restrain people against their will unless there's absolutely no less restrictive alternative. And it's important to explain decisions, I think, to work with staff and patients to help the patient retain her control and prevent hospital-induced trauma should it come to this point. There's many steps before this, of course. And hopefully this will be completely avoided by judicious community care, but explicitly informing the patient of rights and promoting these and actively supporting decision making wherever possible and as soon as possible, and not hospitalising adolescents with adults. Follow-up interventions also, I won't go into this in detail, but there are interventions that apparently do offer some value, and intensive follow-up and green cards, brief intervention and contact, DBT. There's a great need, and Susan's alluded to this briefly, about the need to research alternative approaches like safe places and peer mentors, also brief interpersonal therapy. The implementation of mental health service recommendations works in services. So services that implement recommendations have significantly lower suicide rates than those who don't implement recommendations. So this indicates the services actually, by using good processes and by following people up and assertively looking after people and actually kind of exploring hazardous outcomes and a number of other things, having 24-hour backup. These outcomes actually do work. This is UK research from last year in the Lancet. Drugs may work to treat symptoms or underlying disorders like antidepressants or anti-anxiety or antipsychotic meds, but they can be misused for overdose. You have to be very careful about that. And this is not a panacea. I mean, they're adjuncts, really, except in probably rarer situations like psychosis or melancholia, but or severe depression. But the antidepressant story, just in terms of antidepressants, is confounded by drug company marketing and disease mongering. Among young people, SSRI antidepressants are rarely associated with suicide. They seem more likely to be effective in moderate to severe depression and related conditions such as anxiety and OCD type disorders, but the placebo effect's also marked. So this is a complex story which we can talk more about if we have to. So in terms of interviewing, I'd be very concerned to have a private situation, to be talking to Caitlin in, to try to let her tell a story and encourage this, to learn. My principle generally is to try to learn, to adhere to assessment structures. I'd encourage people to learn the structure thoroughly, but then listen and follow the patient carefully. Leave the structure aside. Follow the narrative. What's the existential and spiritual issue? And all the things that we've already discussed discussed about Caitlin are relevant here. Her social circumstances, the problems and stresses, but also her strengths, which are quite remarkable, I think. The events, perhaps around self-harm previously, the issue of the coping strategies, which we've also already alluded to, and the supports that she currently has, obviously being aware of the safety issues and being aware of intent. So I guess one of the questions is, how does one establish a relationship in the situation, acknowledging her fear? How does one repair and establish trust with mental health services? This is going to take time. She's going to have to decide whether she can trust those with whom she deals, just as they must listen very carefully to her and seek her point of view. Is there anyone whom she trusts who could accompany her, help reduce her anxiety, help her to care for herself and solve some of the problems that she's currently dealing with her university work? Tim's alluded to this, and also in relationships, and also protect her rights. I guess the question of how to respectfully obtain a history, including eliciting delicate information with sensitivity. The issue of, as I said before, understanding her strengths, capitalising on her, her understanding of her situation, the role of the question about her illness. I've just lost my train of thought briefly here, and was trying to read something that I've written on a piece of paper.
That's fine, Michael. I must say you're getting the record for doing the greatest number of slides in the shortest minutes. So please.
Well, indeed, I'm tending to skate over them. What I was wanting to refer to is the issue of hope and the issue of how you generate that. And I guess focusing on things like goals and pathways and agency, as one way of understanding that. But also, I think the issue of her previous recovery. How did she manage that? How does she care for herself? We've already got quite a bit of information about that. What information does she have about the problems that she's facing? And then, I suppose specific therapies that may have been helpful for her, or may be helpful for her that, may be offered potentially. And I guess I've already sort of alluded briefly to medication. Susan's already alluded to various forms of therapeutic intervention that may be useful. So, look, I think probably I'm going to leave it at that and wait for questions.
Thank you very much, Michael. That was fantastic again. Actually, I would like to ask you to address one of your questions. Because you had a really significant one, I think. We've spoken a lot about fear, and the young person in the case study probably has a lot of fear about things, but so do a lot of the practitioners that people come across, as David alluded to as well. So I actually wondered if you wanted to ask your question to David, and we'll invite David to respond to that one.
Yeah, remind me exactly what it was, Mary. I think I was wondering about fear, and specifically personal and institutional fear, how we can begin to address this and overcome it as a key barrier to collaborative care.
Yeah, so I wonder if, David, you could comment on, from your perspective, how you think we could overcome some of the institutional fear that we have. And we bring up all the panellists again. Thanks, MHPN.
Okay, it's asking me for my camera.
And we can hear you already, David. So you can
In a word, the answer to Michael's question, which I have a copy of it here, is a bit of humility. And it's difficult when you try and take that to the institutional level. That's part of his question. But I go back to my comments about recognising the power hierarchies in the suicide prevention industry. And institutional humility is not something that we find much of. Individuals are good at it sometimes. And the sort of phrase that comes to mind are things like, there but for the grace of God go I.
You approach the person first and foremost as a person,
and we seem to have lost contact with this. The clinical approach seems to distance us from the humanity that we're dealing with here. So it really is, I think, a major cultural shift that's needed for the sort of change that Michael's asking for in his question.
Thanks, David. And I wonder, I've actually had some really interesting questions from the audience that I might ask Susan if you could comment on. And I guess we've been talking about the kinds of supports that can be helpful to people that might not necessarily be quote-unquote health professionals. Susan, I know that you've had a lot of involvement with Lifeline, and there's been specific questions about Lifeline. So I wonder if you could just comment on that, on how helpful they can be, are they the right people for suicidal people to call, and so on.
Yeah, I guess it comes back to the fact that really suicide and suicide prevention is everybody's business. One doesn't have to be, a highly skilled mental health clinician to be able to support somebody who's suicidal. Really, you just have to be a human being that cares about other human beings, and I think that's what it comes down to. We've forgotten about this village that we live in, and we are actually all interconnected. So when it comes to Lifeline, and I've noticed that Anne Evans has been writing a lot of comments and is doing a lot of work with Lifeline currently. So if you want to scroll back and look at some of the comments that she's been making about the online chat service that Lifeline offers, people have been calling Lifeline for 50 years, and I think that's because they get something out of it, and I think what they get out of that is that there is somebody who cares and listens. I think it's unfortunate in our mental health structures that we are very time limited, and often you can't. It's quite difficult and uncomfortable to enunciate to somebody what it actually feels like to be suicidal. It's not something that you can fast track, and Lifeline is an opportunity where people are supported and aren't in fear of revealing that they're suicidal. They're not in fear of there being some institutional kind of liability and risk reason that would curtail that. People call because they just want to be listened to. They don't want to have to. Often when you're talking to a clinician, you have to think about what are they going to do with that information. If you're talking to a family member, you have to think about what are they going to do with the information. People just want to tell their story. They want to be able to sit in a safe place, and it's a black place to go. So it's up to us to sit around people to make it safe, to make it okay for them to, I guess, wallow in the awfulness of it, so that they can truly understand it and then move away from it. So the trip that I took looked at a number of places where well-trained and well-supported volunteers who bring a caring perspective are incredibly helpful. Suicide is a crisis of living, and we live around human beings. So I'll just leave it at that.
Thank you, Susan. Michael, and I'm going to ask Tim this one actually. A member of the audience has just contacted me directly, which I didn't know was possible, but it was very appropriate because he pointed out that none of us have actually said that we would have asked Caitlin why she's feeling suicidal. So Tim, I just wondered if you could respond to that, and is asking somebody why they want to die or why they're feeling suicidal something that you do directly ask?
Yeah, a very good question, and just a bit of background to that. Can you hear me okay?
Yeah.
Yeah. I think one of the common threads with all of the panel today has been the need to listen and understand, and that sort of goes across no matter who's there with the person, their professional background or their education or whatever. So I think that's a really important thing. There's some fundamentals that aren't rocket science that we can employ to assist the person in mental distress. And the same with the therapeutic background, the CBT, DBT. My particular training is in a approach called solution-focused therapy. And in solution-focused work, we don't ask why, because why is speculative. And we can go on for a long time about why someone might be suicidal. It's how people cope. What have you done to keep yourself safe, and what stopped you from ending your life up to this point? What keeps you going? who's helpful for you. I think why questions, unfortunately, can get us all a bit circular and not really get to the nub of what people need in their lives to be different. So it's a really well asked question, because I don't ask my questions, and I also dissuade people from asking what if questions, because that's again sort of speculative and not that helpful.
Thanks, Tim. Now, we're talking about maybe what hasn't been helpful, but I know that you had a question for David. I wondered if you would like to ask him the one about what he did find helpful.
Yeah, and I think David kind of answered that in his presentation as well. Is, what has he found helpful or unhelpful in terms of the services or support that he's received in his involvement with healthcare.
And I think the audience are particularly wanting to know what was helpful for David in his experience. Yeah. David, we can hear you. We can't see you, but we can hear you.
Yeah. I noticed there were some questions from the audience around that as well. It's pretty really, because it's much easier to say what was not helpful. And I've just come back asking for my camera, so I'll click the buttons and hopefully the visual's back. Okay. Look, I can think of all sorts of little things. Someone told me very early on, I had about 4 years where I struggled with it, that, it will get better, Dave. But it was just unbelievable for me. Look, I don't want to spook my book. I have to refer people to my book where I talk about all sorts of things, but some of the spiritual teachings that I learned, because for me, one thing I have to say, I should have said it in my talk, is one of the things that we must always be cautious not to do in talking about suicide is falling into generalisations. The first law of suicidality for me is beware of generalisations. And I have an interest in spirituality because obviously, it's an obvious interest because that was the key for my recovery, but I do not regard spirituality as some sort of universal panacea. So I could talk about some of the spiritual truths that finally resounded for me and helped me make sense of what I was struggling with. And some of them sort of almost throwaway lines, like I learnt that I was not who I think I am. I'm not a human being. I'm a human being, not a human thinking. That I was not my mind, and the spiritual truths that let go of the anguish of the mind was to recognise that the mind is not the centre of my sense of self. Now that's just for me personally. I could think of various other things, and I guess I try to sum up with that capacity to be with. In terms of people wanting to help, I saw a lot of psychologists, psychiatrists, therapists of all kinds, and only one or two of them were actually helpful. Mostly they were not helpful, and a few were distinctly harmful. And the ones that were helpful were those that had the capacity to be with me, all of me, in all my madness, in all my chaos, without judgment, and to allow all of me into the room in whatever was going on during that session that I spent with that person. And then I can't point to any one thing that was key for me, but I can sort of boil it down to, respect for suicidal feelings, in contrast to that panic response, which says, this is scary, we've got to stop it. Whatever we do, put the lid on it, drug the person into a stupor, whatever we need to do, we just need to do whatever it takes to stop this now. But actually allowing for a person to have... Okay, here's last comment I just remembered. It's a sort of spiritual truth for me that there is a space between acknowledging and recognising and respecting your suicidal feelings and acting on those feelings. Because I always urge people to allow themselves to recognise the feelings that they're having, because they're significant, they're important. But at the same time, that does not mean that you need to take action upon those feelings. And there's a space there between those two, where if you can just, again, be in that space where you allow the feelings without acting upon them, then it's possible to find a path out of there. Now, I realise this is an unsatisfactory answer to many people, but I mean, I struggled with it for 4 years before the penny finally dropped for me. And I know for some people it's a lot longer than that. But there is no one snappy answer that worked for me, and the same there's certainly no one snappy answer that will work in any general sense.
Thank you very much, David. We're very rapidly approaching a close. So David, I hope you won't mind if we use that as your summing up. And I'll just ask Tim.
Oh, there's one other comment I'd like to make as a summing up.
Please.
Do you want that now?
Yep.
Okay, it's just, I have a real discomfort about the whole discussion tonight, in that over the last 10 or 12 years, I've attended all sorts of suicide conferences and seminars and workshops and read literature from all around the world, and you hear all this good stuff like we've heard tonight, but there's a real clash, a real conflict between what we've heard tonight and the day-to-day reality out on the street for people like Caitlin. And there's all this good stuff that's been said. A lot of it's been said for years, but it just doesn't seem to be filtering down to the day-to-day reality of suicidal people, or the day-to-day reality of our mental health systems. And I really feel I need to throw the challenge out to people like Michael, who is chair of Suicide Prevention Australia, and perhaps Susan, perhaps unfairly, she's got the Beyond Blue banner in the background there, because for me, Beyond Blue are the champion of this disease mongering that Michael talked about, blaming everything on medical illness called depression. And this is a real crisis. It's just a crisis for all of us, that this has become the prevalent thinking in our society. And we have nice talks about this, but nothing changes. So we're the leaders who are going to create some motivation for changing this. I've tried and I'm worn out.
Thank you, David. Michael, have you got 30 seconds to respond to that challenge?
Look, David and I have discussed things at great length, and I hugely respect what David is saying. I sometimes find it uncomfortable being a psychiatrist, sitting in my psychiatrist's shoes, but truly what he's saying is absolutely crucial for doctors and psychiatrists in particular. And I think we really have to explore perspectives of those with lived experience much more rigorously and actively. I think we have to be much more aware of the human rights of people in these situations, and I think we've only really begun to scratch the surface with this. I strongly commend David's book. And I think that we have a long way further to go to try to understand, I think, the difficulties of institutions and doctors, being and people generally, or administrators, being held ransom to processes that actually disadvantage them, managerialism that actually disadvantages them, and I think probably things that are influences that we don't look sufficiently at, but in fact shape the way we see things. I referred earlier to insurance claims and stuff to do with that area of things, but also the influence of pharmaceutical companies and their influence in relation to generating new diseases and Me Too type medicines and so on. I'm not claiming that medication. I noticed Jacinta wrote a terrific post about medication. I would be the last person in the world to forego medication for people who need it, who are in dire straits. And there are people who certainly need medication with whom we will readily prescribe. But I think we have to have our eyes open about the way things are particularly about this particular issue and how it shapes, and the fact that we lose the art and the craft of our practice in the science and in the management. No, that's fair enough. David's been throwing me that question for a long time, and I continue to find it difficult, and I hope he will continue to plague me for as long as we both are friends. I think it will be friends for a long time yet. David's been a persistent campaigner for 10 years, and he's on the money.
Oh, I thank you for that opportunity. And my sign here, David, is hiding a plethora of mess. So, but I want to let you know I accepted the job here at Beyond Blue to make a difference, and I can make a commitment to you that my views, which are very much aligned with everybody on the panel, will be steering this organisation to be embracing suicide and suicide prevention in a way that does make a difference. And one of the quotes that I put into my Churchill report, which I'd encourage you folks to read if you're interested in non-clinical support for suicide crisis, is one by Edmund Burke, and it says that evil happens when good men do nothing. So this is a panel of good people, and we have 500 other good people, and I think that's how we make a change. That we don't sit silently and we don't sit by, because we have to speak for the vulnerable people who can't speak for themselves. So I certainly make a commitment to you and to everybody here that I will be doing all I can to take this knowledge and this goodwill way beyond this panel.